How's everybody doing? Really? Anybody depressed? No? Anybody here never treat depression? Good. Then you can all stay. Good. All right. As the topic implies, major depressive disorder, you guys have all seen it. I mean, in primary care, it's so incredibly common. And most of what I'm going to say to you today is not going to be new, but hopefully at the end of the 45 minutes, you have a couple of pointers on what you can do to some difficult patients, both in diagnosing and in treating and in follow-up. Give you some pointers, but also maybe some information on what you can do with your ancillary help, whether they're psychologists, psychiatrists, or even your office staff. So major depressive disorder. Here's some of our educational objectives: to select and initiate antidepressant treatment regimens based in part on the patient's depressive symptomatology, okay? Their physical exams, psychosocial history, functional status, and also prior and current medications. Okay? Second, employ validated screening measures. I'd like to show you some screening measures that may be somewhat useful for you. I use them in my practice. They do help me sometimes. I don't use them all the time, but they can be pretty helpful. And clinical interviews to identify functional deficits, residual symptoms, and related barriers to achieving full remission. One of the topics that red threads throughout my whole talk is trying to achieve remission. That's a critical thing. It may seem intuitive, help your patient to not have any more symptoms. But it's really critical because those who do not are at risk, and we'll talk about that. Monitor treatment response and adjust antidepressant medications as needed for patients with MDD. Formulate strategies for combining antidepressant medications and psychosocial therapies to help achieve and maintain remission. And develop a therapeutic alliance with patients, fostering dialogue about patient-related barriers to optimal adherence and treatment needs and goals. Okay, so that's our objectives. So, major depressive disorder, okay, it has a central role in primary care. Tremendous amount of our patients come in with depression. One of the most frequently seen psychiatric illnesses in primary care setting. Approximately 10% of patients seen in primary care are for depressive disorder. So, if you see 100 patients a week, 10 of them were depressed, okay, to a certain extent that they need some kind of help. And you may be thinking, geez, well, I didn't see that many depressed patients. Well, only 1 out of 20 patients with depression will report symptoms to his or her primary care provider. Okay, they don't come in saying, I am depressed, I want that medicine that I saw on TV where the woman gets really happy at the end and the umbrella goes away. They don't come in saying that usually. Up to 1/2 of adults and nearly 1/3 of older adults who receive treatment for depression receive it in a primary care setting, so we're the main ones doing it. And we also see the garden variety, the mild, moderate, and severe depression, and not necessarily the extremely severe, the recalcitrant, etc. We don't see those as often. We see the garden variety type. Primary care physicians log almost as many outpatient visits for depression as psychiatrists. So we are doing a huge service for our patients when we identify depression and when we treat them. We need to identify them better. We need to treat them better. And let's go on and see how we can do that. The most common depressive symptoms, you'd think, well, it's sadness. This is a European study. A lot of the patients were in France. So I think French people are similar to us in some ways. Maybe they cook better, whatever. So depression and sad mood, about 80%. Tiredness and no energy, 75%. Sleep problems. One of my biggest passions in the area of medicine is sleep. I think it is so important to ask people about their sleep. Because just as an aside, I'll say this to you. If there's something wrong with sleep, something is wrong somewhere usually, either medically or psychiatrically or something. So if I'm digging at somebody, I will always ask them about their sleep. Getting a 1.5 to 2 minute sleep history can clarify tremendously what may be going on with a patient. Emotional crying a lot, crying spells. But also look at this, anxiety occurs half the time. Feeling keyed up, nervous, agitated, frustrated, upset, anxious, and also fearful. So with depression, a lot of these different symptoms can occur, not just necessarily feeling sad and blue and unmotivated. So other indicators include high utilization of medical care. And think about the patient who comes in 2-3 times a month to see you. My gosh, you wonder what the heck is she going to say this time when she comes in. Amplification of somatic symptoms. Oh, my back pain is the worst anybody's ever felt in their entire lives. I have the worst back pain ever. Nobody's ever had it worse than me. Okay? Increased functional disability. I can't work. I can't work this week, next week, and for the next year or so. Okay? Decreased self-care coming in. You can see that they're not dressed well. They got food on their clothes, that sort of stuff. Decreased self-care and decreased compliance with medical regimens. and lifestyle change regimens. They're just not taking care of themselves. They've lost interest, not just in life, but even in themselves. These are all the different clues that you want to look at when somebody comes in with depression. Keep in mind, again, that a large portion of your patients that are not feeling well, and you can't put your fingers around them like Jell-O, could certainly be suffering from depression. So again, to recognize major depressive disorder, these are the emotional symptoms. Somatic symptoms, especially more common in women. Women have a tendency to have a lot more somatic symptoms. Men tend to have a lot more emotional symptoms. Insomnia, fatigue, headache, etc., weight change, irritable bowel syndrome. Women have a tendency to gain weight. Men have a tendency to lose weight. Women have a tendency to sleep more. Men have a tendency to sleep less. As far as the insomnia is considered, in depression, generally the most common insomnia symptom is not trouble getting to sleep, but rather waking up in the middle of the night with trouble falling back to sleep again, or maybe even early morning awakening. Early morning awakening, by the way, is maybe a little bit more in the dysthymic disorder category, but still, one of the really important clues about sleep is if a patient wakes up in the middle of the night with trouble falling back to sleep again, that type of insomnia is more common with major depressive disorder. Patients at risk. Of course, those who have comorbidities, especially other psychiatric comorbidities, but medical comorbidities. I have a slide that shows that. The sicker people in your practice are much more prone to depression. Also, those with substance abuse and family history of depression. I mean, when you look at somebody with depression, you're always going to get a family history, of course, because there's a substantial increase in the rate of depression in those that have it in their family, especially first-line relatives. Stressful life events. You know, we're not immune to what happens in and around our lives. And there are gradations, I'm not going to get into them, as to what's the most stressful thing in life. And sometimes happy things can be very stressful. Like, for example, a promotion at work, a marriage, having a child. These things can be very stressful. Somebody moving in with you, like your son moving back in with you. Ooh, that can be depressing. Okay, so stressful life events. Domestic abuse and violence, which we're getting a lot better at catching, but that's important to ask, especially in women that come in. And older patients, retired patients, patients that have more comorbidities, and especially if their spouse is going through comorbidity. A man who comes in whose wife has multiple sclerosis, and she's become wheelchair-ridden, eventually bedridden, and he's had to retire. He's had to change his whole life around things. He has a much higher probability of getting depression. And, of course, let's not forget about postpartum. I have a woman that now delivered her third child. She came in a week after delivery, and she said, I'm happy now, but I know in a week I'm not going to be. Start me back on that medicine. You know, postpartum depression. Universal screening. I have this up here just so that you may want to consider this. In all of your new patients coming in, when you do a health inventory, you do a review of systems, ask the two screening questions for depression. And what are those two screening questions? You probably know them, and I'll bring them up later. Okay? All existing patients on their annual exam, when you do a review of systems, you know, do you have any trouble with your vision, hearing, swallowing, digesting, urinating, erections, this, that, whatever? Eventually you get to sleep, you have trouble getting to sleep or staying asleep. And eventually the two screening questions for depression, you know. It may not be a bad idea to add that in there as well. And patients presenting with risk factors, ask them at least the two screening questions for depression, which we will get to. A really nice, important thing, slide then for you to know about in recognizing major depressive disorder. So, providing support for screening improves depression outcome. Screening alone, like I was saying back here, just screening doesn't really help. So if somebody answers one or two yes questions, that's not enough. Then you got to do something about it. This is what this slide is intended to show. If you have somebody that screens in, do something about it. And as far as doing something, the remainder of my talk is going to go into that. But a lot of it involves not just what you do, but what also the patient's support structure does, and also what your office support structure does to help the patient with depression. Goals in using scales. Goals of acute phase therapy. The primary treatment goal is for full remission, defined as the absence of sad mood, anhedonia for 3 or more weeks, and less than three or less symptoms of depression remaining. Okay? And patient-specific goals, full participation in family life, back to work, doing things, and back to usual. Patients saying, I'm kind of feeling pretty much back to where I used to be. I'm feeling like myself. Acute therapy can last up to 3 months or so. And some patients need to know that. They need to be patient about it. And actually, folks, you know this very well. When you tell a patient the expectations, realistic expectations, they can learn to live with it. If they don't have any expectations that are cited to them, they'll make one up. And they'll get very anxious about when are they going to get better. So telling them realistic expectations is very important. What I tell my patients is probably in about a week or two, you're going to feel a little bit better with medication. In about 3 or 4 weeks, you better be feeling better. Okay? And I'm hoping that in about 3 months or so, you'll be back to normal. That's what I generally tell my patients. And that's very important. One of the last things you always do with a patient, you guys know this, is to tell them what are your expectations for them. And that's critical, and that will stay in their heads very, very thoroughly. Acute therapy, then, like I said last week, successful treatment requires dose adjustments and trials of different medications in some cases, and patients need to know that. They need to know that all treatments don't always work. And you may kind of have to, in some pessimistic way, tell them that half the time they may not reach remission. Okay? But more than half the time, about 3/4 of the time, the medication will probably be of some usefulness for them. Okay? They need to have these expectations spelled out for them. Recovery. Recovery is defined as the patient remains in full remission, no symptoms, feeling back to normal, despite discontinuation of the treatment, whether pharmacologic or psychotherapeutic. That is our obviously ultimate goal. You know, your patients where, they've been on antidepressant for about 7 or 8 months, they are feeling perfectly fine. You say to them, let's go a couple more months. And then you go a couple more months, you gradually taper them off their antidepressants, they're doing fine. You see them 3 or 4 months later, and they say, I'm still feeling fine. Okay? That's the patient that has fully recovered. In most cases, folks, with major depressive disorder, which usually, by the way, occurs in the 30s and 40s for their first time, and maybe 50s, all right, it doesn't recur. Okay, in most cases, all right, major depressive disorder doesn't. It happens, it goes away, and for most of your patients, you can say, you probably won't have this happen again. If it does, generally something has pushed them into it. Again, a major life event, comorbidities, etc. Okay? Again, if the patient reports psychological well-being and normalization of altered biological markers in the acute phase of illness, if available, has occurred. Case study. Anne, 42-year-old, mother, 2 daughters, 15 and 13. Already I can see that she has some stressors in her life. Consumer goods buyer for a large department store, busy workday all with long hours, which, by the way, is a risk factor. I'll tell you this right now. People who don't sleep as much, who shave off time from their sleep, are more likely to get depressed. People who have insomnia, people who have sleep problems, are much more likely to get depressed. Any kind of broken sleep. Obstructive sleep apnea patients have more likely chance of getting depressed. Restless leg syndrome. You name it. Give me any sleep problem. These patients are more likely to get depressed. Okay? Frequent travel, time zone changes. Chief complaint episodes of GI pain began approximately 2 months ago. Already some somatic symptoms coming up. Okay? No history of GI complaints in her past. No family history of GI cancer. She has some hypercholesterolemia. She's been taking simvastatin for many years very faithfully. Okay? Her BMI is pretty good. Maybe 10-pound weight gain in the last 6 months. Maybe of some concern. Okay? Vital signs are okay. Her blood tests are okay. And, you have an MRI in your back room and you do one and you find out everything's okay. Normal MRI of the abdomen. We'll answer that question later. So, the DSM-4-TR criteria for major depressive disorder. What are the criteria? What are you looking for? Okay? And here are the 2 questions. Right here. Depressed mood most of the day, nearly every day. Feeling sad. And or loss of interest or pleasure in all or almost all activities. Loss of interest, in other words, loss of motivation, or loss of pleasure, that is, things don't feel as well, okay, most of the time. Depressed people have at least this or both, okay? So for a person to have actually major depressive disorder, they have to have 5 or more of these, but at least one of these top 2 have to be positive, okay? That's the DSM-4 criteria. All right? So the remainder of them are significant weight loss or gain, as I talked about it, with women more gain, with men usually loss. Insomnia, hypersomnia, I talked about that. Psychomotor agitation and retardation. I ask my patients, how are you able to think and concentrate? I can't get my stuff done. It's taking me twice as long to get anything done. And I'm making mistakes. I'm an accountant. I'm making mistakes at my workplace. Stupid mistakes. My mind isn't working well. Okay? Fatigue, loss of energy. I'm so tired. I'm tired all the time. I have no energy. My mind doesn't work well. My body doesn't want to move. Okay? Feelings of worthlessness, excessive or inappropriate guilt. Okay? Diminished ability to think, concentrate, and indecisiveness, like I said. and recurrent thoughts of death, suicide, you always ask every single person with depression about death, dying, and suicide. You know, have you thought a lot about death lately? Have you thought about being dead? Have you thought that you would be better off dead? Gradually ease into it. Well, have you actually thought about harming yourself? Have you thought about killing yourself? Gradually ease into it. Don't just say to them, have you thought of putting a gun to your head and blowing your head off? Ease into it. These are sensitive people, you know. So you ask them questions like that. Have you really thought of hurting yourself? I don't know. I mean, how have you thought? And even if they say yes or no, then ask them the next question. Have you ever in your past, have you ever tried to hurt yourself? I saw a girl yesterday at Ursinus College, you know, and she was a 20-year-old thinking about death and dying. Okay, and she wasn't really that suicidal, but in her history, she said, well, in middle school, she actually tried to kill herself by hanging herself. Okay, so you want to get a suicide history as well. It's very critical. There's actually, if we have time at the very end, I can show you there's a sheet of paper that you can fill out to assess in a numerical value the probability of suicide in somebody. If that's important to you, I can give that to you as well at the end. So that's a very important part of assessing somebody's depressive episode that they're going through. Now, as far as the DSM categorization, you can use the PHQ-2, okay, which is the top two questions, okay, PHQ-2. And basically what you do is you ask the patient, over the last 2 weeks, how often have you been bothered by any of the following problems? Little interest or pleasure, feeling down, depressed, or hopeless. Okay, so these are the top two, not at all, several days, 2 or more, and 3 or more, and you can add the whole PHQ-2 for the patient. And let's go all the way down to number 6. If somebody gives you a number 6 where nearly every day they have little interest or pleasure in doing things, nearly every day they're feeling down, depressed, or hopeless, as a 6, their probability of major depressive disorder is more than 78%, and their probability of any depressive disorder is more than 90%. So it's a pretty sensitive and specific test, especially as the number gets higher as a PHQ-2, where you're asking just these 2 top questions. Okay? That's why in the very beginning I said to you about screening for patients with depression with just 2 questions. Screening for them. Just ask these 2 questions and they can tell an awful lot. Okay? Now, the PHQ-9 is where you use all of them, where you're looking at all these symptoms. Now, this is, you don't see it too well here. This is Ann's scoring, okay, where you ask them all these different symptoms, okay, that we came up with in the PHQ, or rather in the DSM-4, and you ask them, how often have you had these feelings, okay, little interest, feeling down, trouble with sleep, etc., several days, more than half the days, nearly every day. Okay, and that goes from 0, 1, 2, and 3, and she checks them off. And you add the whole category up, and I know this is a bit blurry. I don't know why it's come out blurry. If you have it in front of you where you can follow along, hopefully you can see it better. And let me come over here, because this is the summation. So if the PHQ-9 adds up to 1 to 4, it's probably not depressed. And in this person, there's nothing wrong with them as far as depression. And it goes in increments of 5. If it's 5 to 9, maybe mild depression. And by the way, the proposed treatment of this would be maybe watchful waiting, having them come back again, but just keep an eye on them. Okay? I do all the psychiatry at Ursinus College, for example. I do PHQ-9s on all of them. And I saw a girl with just this number. And I told the psychologist, we have 3 psychologists or counselors at Ursinus, and I asked the counselor to follow this patient carefully, but the patient was not suffering from major depressive disorder at that time. 10 to 14, mild major depression. And the treatment plan would be maybe counseling, maybe medication, maybe a combination of both, but a lot that can be done here. 15 to 19, moderately major depression, okay? And in this case, you would have a lot more intervention. And finally, in Anne, her score adds up to 20, I think, what do we got, 23 with her. And so this is severe major depression, and we want to do the full court press on her. Okay? So I think it's a nice way when you do a PHQ-9 to give yourself an assessment of whether there is depression going on, but also the severity, and guide you as to what kind of a game plan you should have for the patient. Okay? PHQ-9. I love to have this stuff. All right, this is now for your remote controls. These white things in front of you, if you wouldn't mind. Did you, interesting question. Did you do a PHQ-9 on yourself while I was doing this? And if so, with your previous slide, can you rate yourself? from those numbers if you did it to yourself. I didn't score myself, number 1. Number 2, I scored mild depression. Number 3, mild major depression. Number 4, moderate major depression. Number 5, severe major depression. Go ahead. We are not going to identify who pushes what button. So go right ahead. All right? Push your answers now, if you have any. I'm going to give you about 5 seconds. 4 seconds. 3 seconds. Let's see what you guys put. Most of you didn't score yourself. Some of you are mildly depressed. Okay. Yeah, I know why, because you have to sit here and listen to me. It's understandable. A little bit of a life stressor. But the reason why I put this slide up is the answer to it is going to come up in a couple of slides, because I have a slide on, actually I do have it back here. Did you know that physicians are more than twice as likely to die from suicide than the general population, and that depression affects an estimated 12% of male and 18% of female doctors? Okay? And 15 to 30% of medical students and residents have positive depressive symptoms. So we are not immune to it. In fact, we have a higher probability of it. Okay? Next one. Which interview is useful for patients whose symptoms suggest a need for psychiatric differential diagnosis? The PHQ-9, which was the last one that I went through. The PHQ-2, which is the 2-point screening question. The mini neuropsychiatric interview, which I haven't talked about yet. Or none of these. Go right ahead and put your answer on your remote controls now. Which is useful? Interview is useful. I'll give you 4 more seconds. Actually, it's kind of a trick question, because it's the PHQ-9 is something that a patient does by themselves. You give it to them and they fill it out. Okay? And the mini neuropsychiatric interview is something that you do with the patient using the DSM-4 TR categorization. Okay? So the mini neuropsychiatric interview is probably the best way as far as an interview goes for your patients that suggest that they could have a major depressive disorder. So the mini neuropsychiatric interview, this actually is not just for depression. It came about in the last 10 years or so, and it's for 18 different psychiatric illnesses. Okay? It is a questionnaire that an interviewer does with a patient that takes only about 20 minutes or so. It's designed to have you ask poignant questions to a patient to get to a diagnosis. And there are, like I said, 18 different diagnoses, including depression, depression with melancholia, suicide, agoraphobia, anxiety, OCD, etc. And I have it here, by the way, if any of you want to see it at the very end. It's really neat, and I can tell you where to get a copy of it if you do a lot of psychiatry. It's really nice, and it can even help you code exactly what the diagnosis is in the ICD-9 coding. All right? It's a brief, structured interview. Okay, and includes all these different kind of things. It takes about 12 minutes or less, and any clinician can do it, or maybe even one of your office staff members can also be trained to do it. Okay, and it's useful for patients whose symptoms suggest a need for psychiatric differential diagnosis. They're sad, they're this, they're that, they have some somatic symptoms, and you want to get to the diagnosis, and it can really be helpful when you have the mini neuropsychiatric interview. Okay, and this is what it looks like for depression. It's pretty much all the same questions as I showed you in the PHQ-9. But instead of 0, 1, 2, 3, it's yes and no's. So again, the top 2 are the 2 screening questions. If it's yes to any one of them, then you go to the bottom ones. And if there's a yes to 4 of these, then the patient does suffer from major depressive disorder. So this is, again, clinician-driven. You're the one asking the questions. And it is suggested that you ask them exactly the way they are written. Okay, exactly the way they are written. And that's how the mini neuropsychiatric interview is done. And again, you come up with the diagnosis using it. All right? Now, once you have ascertained that somebody has a depressive disorder, well, sometimes they're not just sad or depressed because they have a major depressive disorder. They could have dysthymia, which are those patients that are always sad and blue. They're not really majorly depressed. They're not completely dysfunctional, but they're just sad all the time. They never have a good day. Well, maybe in the last couple of years they've had a month or two where they felt fine, but they're sad. You know, if here is the water level, they're always sort of down here. They're not drowning, but they're somewhere here all the time. You know, and these people suffer from insomnia as well, where they wake up too early, too often. All right, they're difficult to treat, but again, their typical treatment is antidepressants. Depressive disorder not otherwise specified, NOS, I guess. Bereavement, we all know what that is. Psychosis, there are some patients who suffer psychotic episodes and they can have depression. Substance abuse, always ask your patients. It's difficult in my practice in the college situation where I ask them, do you do drugs? How many times are they honest? Come on. Do you drink alcohol? Never. Yeah, right. Substance abuse, always ask them about drugs, alcohol, especially marijuana. Anxiety disorders and bipolar disorders, which I think is very critical for you to make sure of when you have patients coming in and suffering with depression, because if you treat them for major depressive disorder and they're bipolar, sometimes you can actually make matters worse. Okay. Yeah, I am bipolar. Okay. So let's talk about bipolar. There's a couple of features about bipolar that I think you need to know. All right? Abrupt onset, seasonal vulnerability. Okay, vulnerability around reproductive cycle, psychotic symptoms, migraines, subsyndromal hypomania, not necessarily manic, but subsyndromal, antidepressant misadventures. You give them an antidepressant and all sorts of symptoms crop up. Okay, they don't get better, but not only that, but a whole bunch of different symptoms can occur. And greater proportion of the time they are ill. But also a couple of other things that you need to know about bipolar. It's very strongly associated with a family history. Oh my gosh, my mother, my mother's sister, my mother's father, they all had major mood problems. Yeah, they ended up in the hospital. Yeah, he ended up killing himself. I mean, when depression is all over the map, you know, family history is much more likely to be going on with bipolar. Okay? Earlier onset, I see it a lot in the college students. Okay? It comes on in mid to late teens or even in the early 20s. As severe depression. And interestingly, with bipolar, there's a much higher probability of suicidal thinking and suicidal action and suicidal completion. Okay? So earlier age of onset, higher rates of recurrence with short intervals of well-being in between. Okay? If these patients, you know, coming in like in their 20s, you're really depressed now for the last 2 months. Have you had this before? I had it in my senior year, and that lasted about 7 or 8 months or so. Oh my gosh, yeah, when I was in grade school, or rather when I just went through puberty, I was depressed for like 2 years or so. My parents took me to the psychiatrist, blah, blah, blah. You know, so again, high rates of recurrence with short intervals of well-being. Higher number of episodes. Hypersomnia. These patients have trouble getting to sleep. They may not be able to fall asleep at all. You know, I try to fall asleep and I can't, you know. And sometimes if I do, I'll wake up. But most of the time, I just struggle to fall asleep. Again, a sleep symptom helping you diagnose a psychiatric condition. Psychomotor retardation. Yeah, my mind just doesn't work well. I think I need ADD medicine. Yeah, that's what I need. I need Adderall, right. A big desire amongst college students, okay. Postpartum episodes, again, more commonly we'll see postpartum depression being from patients that have bipolar disorder. And finally, weight gain is more common in these patients than weight loss. A couple of things that you want to know then as far as the interview. You want to ascertain about mania, hypomania, that kind of stuff. First episode of depression, early onset. Ask about ask family members, ask about cycling. But one other thing which I don't have a slide here for, okay, and that's a Hirschfeld scale, otherwise known as a mood disorder questionnaire, okay, mood disorder questionnaire. I like to have it in my screening tools as well. When somebody screens in positive for depression, especially young people, I like to give them a mood disorder questionnaire, okay, or an MDQ. I can give you a copy of that as well. I just don't have it up here. I wasn't able to put one on. But an MDQ can be very useful in trying to ascertain whether somebody does, in fact, have a mood disorder. Not just depressive, but mood disorder. All right, moving away from those kinds of psychiatric conditions, let's go to medical disorders. Folks, as I said in the very beginning, it's much more likely for somebody who has a major depressive disorder to have comorbidities. Or put it another way, it's much more common for those who have comorbidities to develop depression. Okay? Patients who are sicker have more likelihood of being depressed. People who have depression are much more likely to be sicker. Okay? So in your patients that are coming in with cardiovascular disease, okay, with chronic pain syndrome, there's our favorite diagnosis. Don't we look forward to our fibromyalgia patients? Okay? How many here love seeing fibromyalgia patients? You love it? Oh, great. Oh, wonderful. Yeah, you're laughing. Okay, reflex sympathetic dystrophy, low back pain, chronic pain, etc. Actually, you know, I like challenges. And I invite people to come in for me to take care of their multiple conditions, including chronic pain. And I spend time with them, and I try to understand them. And I think that it's very rewarding when I get them to be feeling better physically and then eventually feeling better emotionally and getting them back into a more functional life. I kind of do enjoy that. Okay? Metabolic and endocrine problems, they're all listed here, including diabetes and COPD, asthma, kidney disease. Patients with medical problems, the more that they have, the more they can develop depression. So again, what are you thinking here? Remember my first couple of slides, somebody coming in with 4, 5, or 6 comorbidities? Now and then ask them the question, how's your mood lately? Are you feeling sad by any chance? Or are you feeling down? How's your motivation and things? Are you enjoying life just as much as you used to? You know, maybe what you're thinking right now is, I don't know if I want to open up a can of worms like this. Well, yeah. I mean, if a patient is in fact suffering, your job is to see if they are and to treat them towards well-being. So keep in mind, again, medical disorders and medical comorbidities. Okay? So as far as referral strategies, I'm actually going to come to this at the very end as well as far as referral strategies are concerned. But when you refer a patient to a clinician, to a psychiatrist, a specialist, there could be several different reasons why. The patient is suicidal, psychosis, bipolar disorder, case is sensitive or clinically complex, the case is unclear, patient has chronic psychosocial problems, or the patient just wants to go to a psychiatrist. Or just, you don't necessarily like treating this kind of a disorder. These are the kind of patients that you may want to consider sending them to a psychiatrist. Remission rates, okay? Our remission rates in primary care are pretty much the same as they are in psychiatric care. They don't necessarily do any better of a job than we do. They have the same tools that we do. Okay, I mean, we do a pretty darn good job. Okay, so the remission rates, but look at the remission rates. They're like around less than 50%, in at least this, the QI-DS categorization. And in the Hamilton D, remission rates are not that good. So we're not, we don't really do as well as we probably should be doing for our patients with major depressive disorder. And there's a lot of barriers why this happens. Patient noncompliance, a patient with psychosocial programs and access to care, system barriers, but a lot of times patient resistant to the diagnosis and treatment. And that's where you come in. That's where your actions, your discussions, you're seeing the patients frequently, you're talking to them, having your office staff talk to them is so critical in helping our patients as far as modifying these barriers. All right, treatment. Who do you send for to what, and who do you give what to whom? Right. Pharmacology, psychotherapy, combination, psychosocial interventions, and patient self-management. Okay? Which treatment modality, I'm going to ask you this, may be used as monotherapy in mild to moderate major depressive disorder and is generally preferred by elderly patients? Go ahead, make your selection. Give you 4 more seconds. Let's see what you guys said. Psychotherapy, yeah. Actually, psychotherapy is not a bad choice. For mild to moderate, send them off to somebody, send them to counseling. Don't necessarily stick a pill in their mouth. So it's not a bad idea for mild to moderate, especially preferred amongst the elderly. Pharmacotherapy may be used in mild moderate, psychotherapy and monotherapy in mild to moderate, combination, psychosocial interventions like problem-solving treatments. Maybe you don't do it, but you send them off to get that done. Patient self-management. Exercise is not a bad idea. Increased socialization and also self-help. I love to send people to the library for self-help books. I have some great ones in mind if you want to. I can talk about them at the very end. Effective psychotherapy generally requires a minimum of how many weeks of sessions? Is it 4 to 6 for psychotherapy? 4 to 6 weeks, 12 to 16, 26 weeks, or more than 48 months? No, weeks. Go ahead, make your selection. Yeah, about, as I said in the very beginning, about 3 months or so is all that you really need for most people. 3-4 months or so of psychotherapy. I tell my patients, go for about 10, 12 sessions. I also tell them this, okay, to whoever they go to. After about 2 or 3 sessions, you'll know whether you're going to the right person, okay? You'll know. If after 3 sessions or so you feel as if this isn't going to work, don't bother going anymore. Because, I mean, it's like anything else. If you try out a particular flavor and you don't like it, don't go there anymore, okay? I'd like to tell that to my patients. Psychosocial treatments. Among the available ones, cognitive behavioral therapy, interpersonal therapy, all these different kind of things can be helpful. Leave it up to your therapist to pick the right one. Okay? Psychodynamics, psychotherapy, family therapy, etc. Leave it up to your therapist. I have a good psychology and counseling group right next to me in my building. They do a wonderful job. We work closely together. I leave it to them to pick the right kind of therapy. As with pharmacotherapy, monitoring is the key to assess effectiveness and ensure adherence. And generally, the psychologists, psychiatrists, and the counselors will do a pretty good job with this kind of treatment. So, yeah, just give me the drugs. 30 minutes of exercise a day can reduce depression by 50%. Just give me the drugs. So in some people, they come in, they say, I just want medications. So these are all the different kinds of medications. You all know them, okay? SSRIs, SNRIs, mirtazapine, bupropion, tricyclics, and MAOIs. These are all the different medications that we know. And you have your favorites. You know which ones you start with, okay? They all have their advantages and disadvantages. But also there's some augmentation therapies. Why do we have augmentation? It's a slide I showed you before, the remission rates, okay? At best, the remission rates for our patients are going to be anywhere from 25 to 50%. Okay, with a medication treatment plan that we have. So a lot of times you're going to have to do something more. Okay? Sometimes you add a second antidepressant. Lithium. I'm not a big fan of lithium, I'll tell you that. Maybe you guys are, but I'm not. Anticonvulsants, I like using them. Okay? Especially if I suspect bipolar affective. Thyroid hormones, I don't do. Psychostimulants, I do occasionally in some of my patients. Atypical antipsychotics, I'm a big fan of them. They have some good data on them, and I like 2 or 3 of them, and they really make a huge difference in some of my patients that just have major depressive disorder. Okay? And anxiolytics in some patients may not be a bad idea. Okay? Be vigilant to increase side effects, and also one other thing. Almost in every instance, when you start an antidepressant or increase it or add a second one, you are going to have an increase in suicidality. Always tell your patients, if you feel as if you get a little bit worse, that's not such a bad thing initially. But if you're really bad, especially if you're getting a lot of thoughts of suicide or killing yourself, please call me right away. One of the things that I always tell my patients is please call me with any kind of problems that occur in the first couple of weeks. Okay? Some patient-specific considerations. If a patient says, I would like to try this drug, great. There's nothing better than a patient who picks a particular medication if it's the right one. Okay? As they say down in Philadelphia, our educated consumer is our best customer. A patient who likes something about a particular medication is going to be much more likely for them to do well. Prior response to a medication, anticipated side effects. No, my mother took that and her hair fell out. I'm not going to do it. You know? So don't prescribe that medicine. Comorbidities. In certain instances, there are certain comorbidities that you want to be vigilant to. Let's say, for example, an atypical psychotropic you may not want to use in somebody with diabetes, maybe. Potential drug interactions, and also cost. You have to think about whether the patient is going to be able to afford a medicine. Now, this is a slide that shows the pharmacotherapy for MDD, SNRI, and SSRIs, and this is odds ratio for remission. Okay? And this is a meta-analysis showing all these different studies coming together and showing that maybe, as far as remission is concerned, maybe, and this is just a suggestion for you using this meta-analysis, that it favors SNRIs towards remission for major depressive disorder. As a general rule, for patients that have major depressive disorder, I have a tendency as a result of this to go more towards SNRIs than I do SSRIs. In the college situation that I'm in, the majority of the time when I have a patient with major depressive disorder, I have a tendency to do SNRIs for this reason. All right. Side effects, in the interest of time, I'm not going to go through them, but you all know about the potential side effects of SSRIs, SNRIs, etc. Okay? MAOIs, yeah, you can't have that with alcohol, otherwise your head will explode or something. So you don't want to use that. A 32-year-old male is diagnosed with major depressive disorder. Pharmacologic treatment has failed previously. The patient did not take the medication because of the sexual side effect. Which medicine might you try next? SSRI, SNRI, tricyclic, or go ahead, make your selection. Four seconds. I bet you'll all probably get this one right. Yeah, bupropion. Doesn't have any sexual side effects. SNRIs have just as many sexual side effects as SSRIs, as do tricyclics. There is actually one new SSRI that's unique, which is the only brand name comes to mind is Vibrate. Apparently it doesn't have a sexual side effect. What's the generic to that? I should know it. Anybody? What is it? I don't know either. Vibrate with 2 I's and a Y. You know what I mean, right? Apparently it doesn't have as many sexual side effects. Okay. this is just, again, for your own records as far as the metabolism and potential for drug-drug interactions of all the antidepressants here. It's just for your records as well as this one. Common CYP450 inducers. Just about every single one of them, there's tobacco, marijuana, and alcohol. So one of the things that you want to tell your patients with major depressive disorder, where you're treating with medication, if you're smoking, if you're drinking, if you're using drugs, it's not going to work well. Okay? So you have to work with them on those substance abuse issues. Okay? A couple of things about women. Let's talk a lot about women. In women before menopause and when they're going through their cycles, in the last couple of weeks of their cycle, when their progesterone level goes up, antidepressant levels go down. Okay? And that's one of the reasons why, in some cases, what I will do is let's say I'm using sertraline, 25 milligrams for the first 2 weeks, I'll go up to 50 milligrams for the next 2 weeks. That's a nice little trick for women that say to you that right before their period, their depression seems to worsen. Okay, so you may want to have them go 25 to 50, at least with the sertraline. Okay? The reason for this is because increased progesterone also decreases their absorption of the antidepressant. During pregnancy, okay, there's an increase in CYP450 activity, so antidepressant levels decrease. So you may have to increase an antidepressant in these women if it's okay for them to take it. Because as I'm sure you know, all antidepressants are pregnancy category C. Okay? And after delivery, the antidepressant levels will increase. Okay? And as a result, you may want to make some adjustments accordingly as far as antidepressants. And then after menopause, okay, antidepressants will decrease because of decreased estrogenic effect, so you don't necessarily have to use as much of the medication. Other gender differences. For some reason, SSRIs before menopause work a little bit better in women than in men. After menopause, maybe because of estrogenic effect, SSRIs work about the same in women versus men. And MAOIs, if you ever use them. Anybody here use MAOIs? Really? Yeah, you do. Yeah, I know you do. Yeah. And in women, they work a little bit better than they do in men. Some complementary methods. Patients will ask about it. I'll have some patients come in and say, I don't want prescription medicine. What can you offer me? That's where I get out my stick and I dance around and I sing songs. No, I don't do that. I'm just kidding. Acupuncture, maybe, SAM-E, folate, or desmethylfolate. Okay, St. John's wort, exercise, omega-3 fatty acids, whatever. I mean, if you want to suggest them to your patients, it's not a bad idea. Although I would say that in somebody severely afflicted so that they can't even work, they're very disabled, I'm not so sure that I would just recommend these for them. All right, so patient education. Again, as I said to you earlier, that's critical. Okay, talking to them is critical. I mean, we know that it's important in patient improvement, in improved patient outcome with any condition. But with depression, you really want to educate them on the condition. You really want to educate them on the medication. But as I said in the very beginning, you also want to tell them about expectations. What you expect the medication to do and when for them to give you a call. But the other couple of things that are also very important are having your office staff involved with them, phone calls, etc. Okay? Let's go to Anne again. I'm coming down the home stretch. Initial treatment, her functional goals are to reconnect with her family, regain her enthusiasm for her job. Fluoxetine, 20 milligrams a day is given to her. Okay? She recalls that her mother took it 20 years ago and it did okay. And the physician's office is to call and confirm Anne has picked up her prescription and begun treatment. I don't necessarily do that, call to see that they've picked up the prescription, okay? But that's not a bad idea to do in some cases, all right? Symptoms have improved after 4 weeks. She complains of sleepiness. Husband is complaining about her lack of interest in sex. That could be a problem. Oh, I got 2 minutes left. Okay. PHQ-9 is 19. She's still not doing well. I heard you. There we go. 6 weeks later, she reports minimal additional improvement in her symptoms. She complains of additional weight gain, and she notices that she feels sleepy all the time and has little interest in social activities, and her PHQ-9 still hasn't improved. So what would her next step be? Well, here's a nice little algorithm, okay? So initial treatment. As I said to you, about 30% of patients will do okay, they will go into remission. But after about 8 weeks or so, if the patient has partial or no response, you can increase the dose. I mean, you can make her fluoxetine go to 40 or even 60. You can augment. I told you about all different medications that you can add. You can switch. It's not a bad idea either, especially if she has side effects and things. Okay? And if you do that and you've done it 2 or 3 tries, and again, partial or no response, that's where you may want to refer the patient to the specialist. As far as patient monitoring is concerned, well, John, in the past 2 years, you've gone from being extremely depressed to being basically unhappy like the rest of us. My work here is done. Actually, it's not, okay? Because he's unhappy, he still has some residual symptoms. This is the person that's going to be most likely to have a recrudescence of his depression and, in fact, have a higher likelihood of suicidality. I'm going to go all the way forward because I've run out of time. But residual symptoms, again, the more residual symptoms there are, the more risk of relapse. So that's why I want to be so aggressive with making sure that these patients, you eradicate as many of the symptoms as possible with the therapies, whether they are the medications, the medication adjustments, addition of medications, psychotherapy, ancillary treatments, follow-up. All these things are designed to help them get rid of as many symptoms as possible. All right? So measuring remission, one question that I ask them, how are you feeling? Are you feeling closer to where you want to be? Okay? And some of the predictive attrition rates, those that have more medical conditions, those that have never been married, those that have had more than one episode, those that are unemployed, those that have psychotic features, and women versus men. These are the people that are much more likely to have attrition, meaning that they're going to stop treatment and actually fall off the grid. Okay? Discontinuation and non-adherence. I don't want to go through this, again, because of lack of time. Let me just go all the way to this. Yes, here's what I want to get to. The best way to improve medication adherence is to do what? This is a question for you. Provide well-written instructions and educational materials for your patients. Stress the consequences of continued major depressive disorder episodes. Frequently change the medication to reduce side effects. Offer frequent contact and communication, at least 3 follow-up visits. What's your answer? Go right ahead. Four seconds. And the majority of you said offer frequent contact and communication. Yeah, that's pretty intuitive as far as what we need to do. All right. Steps to improve adherence. The most important thing I can say to you, again, is to offer frequent contact and communication, which you guys all know. So I'm going to fast forward here and tell you what happens to Anne. So we give her sequential treatment, augmentation, and adjunctive psychotherapy as her options. She is switched to duloxetine. Her PHQ-9 gets better. It's got a happy ending. And she does really well. Eventually, her PHQ-9 goes to 8. She knows increased interest in her family, and now she is having some relations with her husbands again, having fun again after 12 weeks, and we have a nice, happy ending. All right? So my last slide is also a funny one, I hope. There is a psychiatrist. When do you send a person to a head shrinker who does this? As I said to you earlier, a patient who fails to respond fully. Do you like that one? Yeah. So some specialized treatments are being considered, like ECT or light therapy. Patient develops bipolar disorder, or you really don't want to handle a bipolar issue, or you just simply don't want to tackle that particular patient. Patient has chronic psychosocial problems. Hopefully, I have met my educational objectives. I ran about 2 minutes overtime. What happens now?
Thank you very much. Don't forget to fill out your evaluations, please, and can you join me in thanking Dr. Doghramji?
Thank you.